Good afternoon, everybody. Prynawn da, croeso cynnes I chi gyd. My name is Kat Jones from Hub Cymru Africa, and I'm really pleased to be inviting you to day 2 of the Wales Africa Health Links Conference, Health for All 2020. For some of you who joined us yesterday, you will already have heard the Minister of Health for Zambia speak, and you will have heard a really interesting session yesterday afternoon on women's health globally. This afternoon, I'm delighted to be able to welcome Dr Choolwe Jacobs, who's also from Zambia. Dr Choolwe is a public health professional and expert in women's health. She's the country lead for global women in health in the Zambian chapter, and she's also a researcher and lecturer at from the School of Public Health at the University of Zambia. Welcome, Dr Jacobs. Just before I hand over to Dr. Jacobs, just to remind everybody, the sessions will work as normal. So we've got until 2:30 this afternoon. The session is fully recorded, so will be available for playback later if anybody hasn't been able to join us today. There is a chat function on the right-hand side, which I see some of you are already making great use of, which is fantastic. There is the Ask a Question button at the bottom of your screens. So I'll be keeping an eye on that as Dr. Jacobs is talking. And if there are questions, I'll be making a note. The same rules as yesterday apply, so I do have a handy delete button on the questions. So anything that is abusive or hateful or seen to be rude will be removed from that question function. If there are any other comments that people would like to make, please do keep them to the end. So we'll have about 20 minutes or so after Dr. Jacobs has spoken to ask your questions. That's it from me. I will hand over to you. Please, warm welcome to Dr. Jacobs.
Thank you. Thank you so much. And good afternoon to everyone from Zambia. And I'm delighted, very happy to be in this presentation and for the opportunity that has been granted for me to present on a topic that I'm so passionate about, women's health. This is a topic that keeps me awake at night, because when I think of women, I think of some of the inequities and some of the challenges that women go through, which they actually, most of them shouldn't. As introduced, my name's Choolwe Jacobs, a lecturer and a researcher in the School of Public Health at the University of Zambia. I'm also a member and a lead for the Women in Global Health for the Zambian chapter. This afternoon, I thought we could share our issues here in Zambia and share our experiences in relation to COVID-19 pandemic on women's health. So my presentation, which I've entitled Effects of COVID-19 Pandemic on Women's Health in Zambia, it may take about 20 minutes. So just a quick back, actually is a low and middle income country in the sub-Saharan Africa. In Zambia, more than 58% of the 17 million people that we have, they earn less than the international poverty line of $1.90 per day. And that's statistics that we have. Zambia, you should know, is that it's a landlocked country. I was hoping I could share the map for Zambia or Africa so that we're able to see where Zambia is. So Zambia is a landlocked country surrounded by 8 countries. Currently, we have a population of 17.9 million with 10 administrative provinces. Now, coming to women's health in Zambia, I thought I should share about the burden on women's health in the country. We may know, we may not know that Zambia remains one of the countries in sub-Saharan region with the highest maternal mortality ratios. And although the country has made tremendous progress, remarkable progress in reducing maternal deaths from 591 deaths per 100,000 live births in 2007 to 278 deaths per 100,000 live births in the most recent Zambia Demographic Health Survey, progress actually has been slightly slow and uneven. And we should know that maternal deaths currently account for about 10% of all deaths that we see among women are related to child-related issues. And yet, no woman actually should die during childbirth. On this slide, I thought I should share some of the issues that contribute to some of the maternal deaths that we have. Quite a number of issues, but I've tried to highlight a few. Surrounding women and their health issues are issues such as HIV infections, where 14% of women are actually HIV positive. We also have issues of cancer, such as cervical cancer, where we see that about 2,900, almost 3,000 women dying every year from cancer conditions, cervical cancer to be specific. We also have issues like breast cancer, where we're reporting about 22 per 100,000 women that are being infected or that are being affected by breast cancer. And in fact, about 400 women die each year from breast cancer. Other than that, we also have teenage pregnancies. Now, we should know that teenage pregnancies, really, there are some complications that are related to teenage pregnancies among young people. When they begin childbearing at a tender age, a number of maternal complications come along. And for the country, this is aged between 15 to 19 have begun childbearing. We also have issues that surround us that may be global, I thought we should mention, such as gender-based violence, where almost half of Zambian women have reported or have suffered from GBV. Other than that, we also have HIV infection among young women. This is another challenge and the other public health issue, where almost 5.6% of young women aged between 15 to 24 years are actually HIV positive. So we see that surrounding below the bigger umbrella of maternal mortality that we're experiencing, that we're grappling with, there are all these issues and others that we may not have indicated. However, I want to indicate that Zambia is within the Sustainable Development Goal agendas, and like any other country, we also, in this agenda, we would love to achieve gender equality through the SDG 5, and we're also determined to ensure healthy lives and promote well-being at all ages. And so we are within this agenda for sustainable development goals, where we are aspiring to ensuring that no one is being left behind. To do this, we also do have, other than the global agenda, Zambia is also responding to some of these issues that affect women through policy, through documents that we've put in and guidelines to try and mitigate some of the issues that surround women. And I want to mention the Zambia National Health Strategic Plan that is in place, with a commitment to providing equitable access to cost-effective quality health services as close to the family as possible. And I must indicate that our strategic health plan is coming to an end in 2021, which is next year, with a number of achievements that have been made so far. In relation to women's health, we also have the Reproductive, Maternal, Newborn and Child Health Roadmap that has been helping and guiding us in ensuring that women have quality healthcare services and their needs are met. And through this roadmap, we're hoping to increase availability and demand for quality services that are being provided. This said then, where are we currently? What is the situation? As I indicated, we've had remarkable progress that has been achieved in reducing morbidity and mortality ratios among women. However, I must indicate that despite most of the promising efforts at national level, we see that most women still face challenges in accessing essential services that are key to ensure their health. To demonstrate on this slide, I would love to demonstrate some of the achievements that have been made in Zambia. As you can see on this slide, this is where we're coming from. In 2001, we were reporting almost 729 maternal deaths per 100,000 live births. And over the 2 decades, we have actually steadily reduced these numbers. And in the most recent Zambia Demographic Health Survey, we see a reduction of maternal mortality to 278 maternal deaths per 100,000 live births. However, even if this may be so, we think that no woman in Zambia should be dying from childbirth-related complications. However, I must indicate that even if we have seen this progress and these achievements over the years, we still have issues that we're trying to work around with. And some of the challenges, public health issues, public health challenges that are affecting women in Zambia. As seen here, about 68% of women, only about 68% of women have their needs satisfied with modern methods of contraception, meaning the unmet needs for modern methods are still quite high at about 30%. In regards to contraception use or prevalence among adolescents, only 37% of adolescents are able to utilize or access contraceptives. These are modern contraceptives. Notably too is that only 63% of women are able to attend antenatal care visits before delivery, at least 4 ANC visits before delivery. And so it's not every woman that is able to access this service. According to WHO, the World Health Organization, every woman should be delivered by a skilled personnel. However, in Zambia, about 20% of our women are not being delivered by skilled personnel. Only 80% are delivered by skilled personnel. I should indicate also only 64% of women have been tested for HIV. I should also indicate that based on the Sustainable Development Goals and the buzz for universal health coverage, unfortunately, not everyone is being met. Some are being left behind. But who is being left behind, even with these statistics that have shown? Who are some of these people that are being left behind in a country where most of the health services actually are free in the public health care system? So based on some work that we've been doing, we have found that the young people, adolescents including, are being left behind because they are unable to access some of the services that they ought to. Other than the adolescents and young people, we also, from our work, we have seen that the most remote and rural communities where access to services is still a challenge are being left behind, because for most of our indicators, the rural communities are still lagging behind. Interestingly, though, in our most recent findings, we found that within the urban populations, where we think that people have access to healthcare services, we have most recently, and based on evidence, found that within the urban populations, there are communities that are being left behind, and these are the urban poorest. There's other evidence that is being shown, but I thought I could also indicate that we also see that women that are not educated, actually, they have limited access to some of the services that they require for quality health. On this slide, I thought I should share and show some of the disparities and the gaps within the communities or within this special group of women. In as much as women are vulnerable, within them, we are also observing that there are gaps or inequalities, particularly. So on this slide, I've selected a few indicators that I thought I should demonstrate. The first graph is, I hope it's clear, it's showing percentage of family planning demand satisfied by modern methods. And we see that the least educated, actually, over the years, they've remained behind with lesser coverage, or a number of women that are not educated, actually, they have their demand for modern methods not being met compared to the most educated. The other figure here down is trying to demonstrate the disparities between rural and urban, showing the differentials based on residence. And we can see that urban women, actually, surprisingly, they are becoming least likely to have at least 4 ANC visits. So we have the orange, that is for urban, and the blue for rural. But over the years, we see that the urban population is lagging behind. And in the most recent Zambia Demographic Health Survey, we see that actually women in the urban areas are less likely to have at least 4 ANC visits before they deliver. I have another illustration here on this slide, trying to show the inequities based on wealth quintile. And we see that the gaps have continued, although with time, the gaps between the poorest and the richest is closing up. On this slide, it's about skilled birth attendance, coverage for skilled birth attendance. About 60% women from poorest populations are receiving skilled attendance during childbirth, compared to almost 90% of those who are richer or richest. So the gap still exists within the women that we have in Zambia. This is the same case for postnatal care within 48 hours, where we see that over time, the gap is closing, but has not completely closed, because inequality still exists within the groups of women. Now, the next question that we may want to ask, particularly for the Zambian context, which may be similar to other African countries and other countries elsewhere, is the question of why are some women being left behind? Why is it that not everyone is accessing these services and a certain group of women are better off than others? And I should indicate that through this slide, it has to do with access to quality healthcare services. And some of the factors include distance to the health facility. Through the work that we've done, some women have reported that to get to the facility, particularly during pregnancy, and to make it for 4 times before they deliver, most times becomes a challenge because the distance to the health facility is a challenge. And in most recent, we know that our guidelines have changed, where women are supposed to have 8 visits before they deliver. And this is becoming a much more challenge for women that are in hard-to-reach areas. There's also an issue of lack of transport to the facilities. As I indicated earlier, we have about 60% of our population that may be classified as poor. And so accessing transport to the health facilities, the cost for transport for some may not be very easy to get by. And so this becomes a challenge. Other than that, some findings have also shown that services most times may not be adequate. And so this becomes one of the challenges. There's also an issue of inadequate healthcare providers. I think in yesterday's presentation on section reproductive health, there was a beautiful slide that was showing the burden or the countries that are experiencing critical shortage of healthcare providers. And I should indicate that Zambia is improving and is doing, and a lot of efforts have been made in ensuring that healthcare providers are being trained and made available. In some areas, this is still being reported as a challenge. Yeah, but other than lack of access to quality healthcare services, there are other factors that at individual level, and some of them have to do with cultural beliefs, where some women hold these cultural beliefs and values that limit them from accessing the services. And one of the examples that I would give, some women would prefer to be delivered by a female provider than a male. And there are also issues of power and gender-related issues where some women need to get permission before they seek care. And other than that, as I mentioned, there are other economic and social demographic factors. I like this slide in yesterday's presentation, and I thought I could share just to justify when I spoke about shortage of healthcare providers. But this, indeed, I should mention that is becoming better for Zambia, where efforts are being made to train many more healthcare providers. So I think this is what I can say about the current issues. Not necessarily current, but the scenario, the context in which we are, where women's health is an issue and a priority for the country. But then, now we have this shock that the country has also experienced, and this is the COVID-19. Like any other country globally, Zambia has not been spared from the COVID-19 pandemic. We had our first case reported, our first 2 cases reported on 18th March 2020. And since then, we've been seeing increasing numbers of COVID cases, confirmed cases. As of 29th September, we had a total of 14,000 lab confirmed cases. Currently, during this time, as of 29th September, we had about 446 active cases, about 14,000 cases that have recovered, and about 119 deaths that are related to COVID-19. Now, this is our experience. This is how we have also not been left with this COVID-19. And like most other countries, our country, Zambia, is responding to the pandemic we have adopted the WHO guidelines, as was indicated yesterday in our minister's presentation. We are aware that there's been total lockdown in most countries. In Zambia, we had a partial lockdown, not total. So, mandatory mask wearing in public has been instituted. We are restricting crowd size to 50, closure of schools and international travel restrictions, including quarantine. So most of all these measures, all these guidelines have also been implemented in the country. Other than that, we also have statutory instruments that have been enacted to make COVID-19 notifiable. Now, I must indicate that although we have all these guidelines that have been put in place, indeed, we have observed and have seen that a few challenges have been experienced. There have been challenges that have been experienced and have been observed and have been reported, where the individualized access to protective clothing, such as masks, for some people have said it's been a challenge. And this may not be surprising for a country where about 60% of people live below the poverty line. Some households, because of the same economic issues, are unable to afford even the hand sanitizers. And also, I should indicate that staying at home has been a challenge for some communities, particularly in some households that have to live on a daily minimum income. Yeah, so these are some of the challenges that most households have been facing in relation to adhering to the guidelines. But we should also indicate that other than these challenges related to COVID-19, I think there's an alert there in relation to women's health. I want to liken it to this track, the current status. When I think of women, I think of this track. These are women that we know from, even as I've shown through the graph where we've seen improvement in maternal mortality. And over the years, we've known that women are vulnerable and they have a number of issues, health issues that relate to them. And when I look at this slide and this track that may be familiar to some, I think of women on this track that are already vulnerable and at risk and need close attention. And when I look at this and I think of the shock that COVID-19 has come with, where there's need for more attention, there's need of readjustment. And when this track is moving and it hits a shock, I'm imagining these women falling off this track. Yeah. And so because of this, it truly demonstrates that with this COVID-19, there are some immediate effects that are being reported, immediate issues that are being observed on women's health in Zambia. Other than economic effects that I do not want to labor much on, where most of our women may not be empowered economically or may be depending on daily income for their living. There are also issues of psychological effects. Now, Zambia has a lot of culture and values that underpin most of communities, and most of them has to do with social interaction. So with this COVID-19, we know that we've had to self-isolate, we've had to limit movements, interaction. This has truly affected psychologically some communities due to social isolation and individuals. And a number of gender-based violence cases have been reported in relation to COVID-19. I must indicate that, I think the most recent news we had was that although we have these gender-based violence cases that have been reported, however, one interesting observation is that for Zambia, these cases are somehow reducing during this period. I should also report that the disruption with education, where adolescents, most of them who are in school, have not been going to school, has also led to observations where there's an increase in teenage pregnancies. And other than that, in Zambia, we have the HPV program, which other than in health facilities, is being implemented in schools. So we think that because of this disruption, where most school-going children have been home, this program has been disrupted. And I should indicate that COVID-19 has brought in anxieties and fears that have actually fueled in our community members, and women have actually reduced access to essential health services, and this has been reported. And I should also indicate that in relation to this point of reduced access to essential health services, the implementation of quarantine, social distancing has indeed been a challenge, even for healthcare providers in the community that are receiving the services, because it has brought in a lot of fear and minimized interaction, where most women are unable to access these services because of the fears surrounding the COVID-19. Now, these are the immediate effects, but we think that there are other possible medium and long-term effects, and these may relate to poverty levels that we think may go high. We do not know, but we need to explore further. But as I showed on the track, the shock on that track, we think that may disrupt the efforts that are being made to achieve the SDGs, particularly 3 and 5 by 2030. And so, how do we challenge the challenge of COVID-19? And here, these are thoughts, these are suggestions that we think could be integrated, could be implemented, and could already be being implemented, but we want to emphasize. And this is what we are saying. We are saying, let's engage women in making decisions for mitigating COVID-19, because they are the ones on the track that I've just shown. And if they are involved in decision-making, if they are involved, they are engaged in participating for their own health as much as possible, we think this may really help. And and we're also saying that probably we need to do things differently, as it has been mentioned before, by not forgetting that adolescents and women's health, where the burden has its most potential effects, should be still set as a priority amidst this pandemic. And we think that we need specific targeted responses for this group of women's health. Yeah, because these are women, particularly women that are most vulnerable. Some interventions, some strategies that we are implementing. Other than those, we also need to have some that are targeting this vulnerable group of women. We also think that we do not only need to respond to the immediate, but we should also be thinking ahead for the long term. We think that in this current situation, with all the anxieties that COVID-19 brought in, most of our focus was in trying to mitigate, but we need to think through and think about this woman that is a priority and who is very vulnerable. But other than that, we know that in a country like Zambia, we are engaging our communities, but probably we need to intensify more on community-based interventions by engaging communities for their own communities to try and enhance some of their information, communication, and education packages to try and prevent and treat COVID-19. to try and prevent or mitigate COVID-19. We also have the issue of teenage pregnancies, where adolescents, young women are being left behind. We think that team building in communities for adolescents are equally engaged, and they feel they are part of the interventions that are being implemented in the country. Now, in ending, we think that through this links and network with the Wales and Africa Health, there are opportunities that are there for us. And we think that evidence-based interventions, particularly in a country like Zambia, would really help, so that we're not firefighting and then we are aiming for the right targets. And so to do this, we think that we need to continuously generate evidence. And I must say that in a country like Zambia, there's an opportunity to do this, but there may be a bit of limitations. But together as a network, we could enhance this process through supporting think tanks, possibly through small grants, and make sure that we have evidence that will inform the strategies and the interventions that we try to implement in the country in trying to improve women's health. We think that also training modules that highlight some of these vulnerabilities and with a focus on improving women's health could also be another important focus strategy. And this, as earlier indicated, I think in yesterday's presentation, some of these trainings could be done through virtual. Other than that, we think that in this time of COVID-19, and also with another focus of women's health, quite a number of interventions will be suggested and be implemented. But we're proposing that we also need to know what works and what is not working. And so as we continuously think of what works, or as we continuously implement and think of effective interventions, we think that a focus on implementation research would certainly help, as this will help us to know what is working and what is not working. This is where I end my session. I would like to say thank you to the institutions that I've listed here. Thank you so much, and thank you.
And thank you very much, Dr. Jacobs. That was a great introduction to a whole range of issues in Zambia. I think it's particularly interesting for us in the UK to hear the part on COVID as well, because obviously that's a global challenge that we're all facing at the moment. I think some congratulations are in order in terms of your maternal health statistics. The drop in maternal mortality since 2001 is particularly impressive. But then the challenges that you set out there are also quite stark. The statistics around 54%, or at least 54% of women across Zambia suffering some form of gender-based violence. Obviously that would have a huge knock-on effect on women's ability to access any health services for themselves. So I think that's a very clear picture you've given us. Thank you. There's quite a few comments going up in the chat box, and there's also 6 or 7 questions that have come here. We were aiming to end this session at 2:30, but given that we'd started a little bit late, maybe we can give ourselves an extra 10 minutes on the end, if that's all right with everybody. So we'll go until 2 to 3 UK time. I'll kick off with some of the questions that we've got here. We've got one question from somebody who's working with Friends of Chitambo Hospital, Central Province, asking about contact details. Maybe I'll park that one until the end, and we'll see if we can make arrangements for connections with individual groups later. I'm sure it'll be by popular demand, I'm sure. There's a specific question about maternal mortality rate at 278,000 per 100,000 live births, and whether that is uniform across the country. How is it specifically in Chitambo?
Okay. Wow. Sure, thank you. So yes, the maternal mortality ratio that I've shared, this is for the whole country. Specific for Chitambo, yeah, this is close. We need to check, but because this is a district level kind of statistics that would need to pull, usually we may need to present it as a count. Unfortunately, I do not have the numbers with me now.
That's
but
fine.
I could still share with a specific person who's interested. Yes.
Of course, yes. I think is it Joe Valence we've got on who's particularly interested in that area. So maybe that's something that we can take up after the session, yes, to put you in touch with that specific region. We have another question here from Dr. Alison Fiander. Very good question, actually. What do you think makes the most difference to improving women's health? Educating women and girls or providing health services? Big question.
Yeah. Yeah. I think, although it may be both, but we need to start from somewhere. I think as you saw in my presentation that women that are not educated are being left behind. We have had observations where even in places where the services are valuable, most of our health services in Zambia are free. And so we still see some patterns where uneducated people are not accessing as much as they should. So with this observation, we think that it's also critical to educate women, because when women are educated, they're able to comprehend, they're able to understand why they need the services. So probably the basis would be, let's educate women, but let's also continue providing the services.
Right. Good answer. It's both, clearly. Yeah. Another question here around specifically about the COVID response. So why do you think most sub-Saharan African countries have had a lower mortality from COVID-19 than any of the predictions? I think some of the predictions from a few months ago were very bleak. And has the pandemic had a different impact on women?
Okay. I'll start with the second question on, has it had a great impact on women? Yes, it has. COVID-19 has had an impact on women, not only physical, psychological, I think emotional. I say so because a woman in Africa, a woman in Zambia is the source for most of the livelihoods at household level. This is a woman that should participate in providing, in taking care of the family, and also in some households to bring in income. And so with this COVID-19, women have been impacted because of the effects of this COVID, where there's been some limitations on movements, the partial lockdown, and yet this is a woman that should continually take care of the family and take care of other sick people in the household. And so our thinking that indeed women have been impacted on this COVID-19, not only because of the disease itself, but also of the effects that surround the COVID-19. Mm-hmm. Now, coming to the second question. Now, remind me the second question. I didn't take.
Maybe before we go back to that second question, actually, just because there's another linked question around whether, from what you're saying about women, whether they're specifically restricted from selling products at roadside at the moment, whether some of the subsistence farmers and fisher women are particularly impacted. Are there restrictions around women sort of going to market and moving freely at the moment?
So currently there are no restrictions, but where we're coming from, apart from, there's been partial lockdown. The restrictions are not there, but they need to follow the guidelines that have been put in, where they have to minimize interaction. They should have their masks on. And so some of these guidelines have been a challenge for them because some of them have reported that they cannot afford a mask. And there are others that cannot restrict their movements because they have to move around to feed the family and to bring in income and food on the table for the family.
Yeah, of course. Linked to that question, which I think is a big question that many of us would like to hear the answer to, particularly from UK government perspective. How have sub-Saharan African countries, including Zambia being a great example, have managed to have a lower mortality rate overall from COVID-19 than was initially predicted? You might be aware that in the UK, for example, we have had a very high mortality rate, despite having a reasonably strong health system, whereas Zambia has managed to maintain a very low rate. I think you said 111 deaths overall. How is that achieved?
Well, so as you are asking, I'm asking myself the question as well and say, maybe I would not best respond to that question, because I think that's something that I need to check through and read through as well. I may not really understand why we have these patterns where Zambia and other sub-Saharan African countries have low mortality ratios in relation to COVID-19. We could have assumptions, but I think I would love to provide a response that has evidence, that is scientifically evidenced.
Evidence-based.
I wish I could provide. Yeah.
Okay, so we have, I think it's 3 more questions. So again, from Alison Fiander, how specifically can we value and appreciate the healthcare providers working in women's health more?
Okay. So how can we value healthcare providers working with women, particularly during this COVID-19 era or pandemic period? I think there's a lot that we can do for these healthcare providers, because I think they're attending to women that come to seek care, not by choice. Some of them, most of them actually, it's due to natural processes where a woman needs to come and seek care for antenatal care services, for delivery. And so healthcare providers have to be there for them. And I think we really need to value the work that healthcare providers are providing. And for a country like Zambia, I think efforts have been made to try and ensure that they are protected as well. And reports have been provided where healthcare providers have been provided with protective clothing, and to ensure that they are safe as well. And yeah, I think there's much more even beyond provision of protective clothing, where we ought to value the care that healthcare providers are providing, but probably that would be at another level. But from my wish, I would wish that these healthcare providers could be probably motivated much more, but this is dependent on the economy of the country and the decisions made by the government.
Yeah, it's a difficult one, isn't it? I mean, the particular challenges around PPE, we are essentially asking people to put their lives on their line for this country, and it is difficult to know how to fully repay that debt that we will all have at the end of COVID.
Yeah, and probably we may not even be able to pay back for the sacrifices and efforts here on earth.
Yeah. We have a question here about the lack of HCP in Zambia, and how can that lack be addressed?
HPV?
HCP.
Okay. Oh, sorry.
This is from Alison.
The healthcare providers, right? Yes. So how can this be addressed? Well, efforts are underway. The government has intensified training of healthcare providers. And like the past 5 years, I think most recently we've seen a number of healthcare providers being trained and deployed into hard to reach areas. the challenge, the burden was so much, and within this short time, we may not have met the targets, but efforts are underway, and we hope that more efforts, more support, if that could come along, that would help accelerate the efforts that are being made currently.
Mm. Okay, I just want to refer everybody to the chat also, to keep an eye on it on the right-hand side of your screen. I'm seeing that Dr. Charles Masiska, good afternoon, Dr. Charles, is also online, and just referencing the Zambia Public Health Institute, who have currently been researching the low rates of mortality but high rates of exposure of COVID-19, and is saying that apparently a lot of Zambians are asymptomatic but have been exposed. So quite interesting to reference that also. One final question that we've got here on the question and answers is a big question from Paul Myers. Do you think the solution to the inequality for women lies largely in empowering women or in changing the attitudes of men? We're throwing questions at you this afternoon, Dr. Jacobs.
This is tempting. This is tempting. Yeah. I think they fall more on empowering women. Or it could be that it could also fall on the men's side. But I think if we empower women, they'll be able to make decisions that most of them are not able to because they are not economically empowered. And so I think if women are empowered, I think most of the challenges with inequalities may be addressed.
Mm.
Yeah. And because an empowered woman will be able to make her own decisions, and they will not have to depend much more on men. But of course, we need men to support women. And this is why we're saying, let's give opportunities to women also to make decisions and to participate in most of decision-making agendas, so that they also participate for their own health. Yeah.
It's almost, we could almost rephrase that question in a way and say, how do we empower women and support women to make their own decisions and to be able to be economically active and therefore improve their health outcomes, without at the same time alienating and intimidating men, and without there being this power battle, without it sort of needing sort of one sex to be in charge. But how do we promote global equality, where both sexes are happy with the status of the other sex as well as their own status? It's a difficult balance to strike. We have.
Yeah. So how do we do that? Yes, maybe. Yeah. Okay, go on.
No, carry on. There's one last question, but do carry on if you have further thoughts on that. No. So we have one final question here from Joe Vallis, which will probably be the last question that we have.
Comment on how do we empower women?
Do you want to repeat that again, Dr. Jacobs? I think I dropped that there for a second.
Yeah. I also missed your question. I'm sorry. Looks like I'm having challenges with my internet.
It's okay. Let's move to the final question, which is, how does again, another big question, how does the worsening economic situation in Zambia impact on women's health?
I think the worsening economy in Zambia has a huge impact on women's health, because I think on a number of ways, and to start with, economically, women need to be empowered. They need resources to maintain their and to make access to the access. And so with this economic challenge,
I think we've lost Dr. Jacobs there. That was a shame. It was our final question of the session, and we've got only a couple of minutes left. I'll give her just a few seconds to see if she's able to reconnect and to finalise that last answer. In the meantime, I am putting into our chat box, there we are, the feedback session, the feedback form. So we do have a couple of feedback forms in English and in Welsh, if anybody would like to provide a response or feedback to us on this session and how much you enjoyed or didn't enjoy the session. I'm sure most of you will agree that it's been incredibly insightful to learn from Dr. Jacobs and the insight she was able to give us into the work that she's doing with her team in Zambia. I don't think we're going to be able to reconnect with her, so I will extend our thanks to her on behalf of all of us from Hub Cymru Africa and the Wales Africa Health Links Network. I'll end the broadcast here, but do please remember that the broadcast will be online again and will be available on all of our social media channels. So do have another look if it is of interest for you. Hopefully see you again online for some of the other sessions before the end of the health conference. Do enjoy. Have a good afternoon.